Hello, everyone. My thanks for joining us in this session on choosing wisely. Also, my thanks to the organizers of the Congress for the invitation to speak to you today about the Canadian perspective. I will touch very briefly on the American side of things, but mostly we're going to talk about my experience in the Canadian campaign today and a little bit about some of the evidence and work that we're doing around this area. My name is Dr. Kyle Kirkham. I'm an anesthesiologist in Toronto in Canada. I have no commercial disclosures regarding this talk, although I do get some financial support from my associates and my university to do my academic work. In the area of choosing wisely, I'm currently the chair of the Canadian Anaesthesiologists Society Choosing Wisely Committee. And as I mentioned, I do a fair bit of academic research in this area. To start from the beginning, or rather to take a step back, I guess, in 2001, the Institute of Medicine produced the Crossing the Quality Chasm report, and that really is the foundation of where Choosing Wisely came from. That paired together with the Physician Charter that was published in 2002 spoke to the need for physicians to take a stock of their role in the ever-escalating cost of healthcare and ensuring that patients were getting evidence-based choices. When you bring those two issues together, the American Board of Internal Medicine produced the Choosing Wisely campaign in 2012 as a way to really enhance physician role in stewardship of healthcare resources and in ideally helping to control the cost of ever-escalating healthcare costs in the American jurisdiction. This isn't unique to the US, and so Canada followed suit in 2014 with our own Choosing Wisely campaign. You can see from the timeline there that it took about a year for the Canadian Anaesthesiologists Society to do the background work necessary to produce our recommendations. Those came out in 2015, and following on from that, a number of our provincial organizations like Ontario's Anaesthesiologists have really dug into this campaign as a way to build anesthesia profile and also improve evidence-based decision-making for our patients. I put a nod to Choosing Wisely International on this timeline because it's been a major development in the campaign. It's largely hosted actually by the Canadian organization with Wendy Levinson, who you may be familiar with as the lead for driving Choosing Wisely International forward. But many of your countries, if you have a campaign in your country, it's probably supported in some way by the Canadian infrastructure. In 2018, we created a national clinical innovative trials group to really look at implementation science and behavioral science changes that might help us to implement Choosing Wisely on a national level. And we'll talk a little bit about some of how we've got to there. In Canada, our Choosing Wisely campaign is a regional exercise. The national campaign has brought together all of the professional societies to produce their recommendations, much like campaigns in your country might have done. But we recognize that practice change depends on local factors and local participants in order to make it happen. So each of the provinces in Canada has their own campaign. That's allowed us to partner with government and with professional organizations from nursing and other allied health professionals to really look at local solutions that try to take into account the behaviors, the funding, the different practice patterns that we have in each province, even in a country where the health system is relatively uniform, like Canada. In addition to those provincial campaigns, our National Choosing Wisely organization has undertaken a number of national efforts to try to improve care around some pretty important topics. Opiate Wisely is one example where the national campaign brought together our professional societies to bring recommendations forward specifically around opiate prescribing, opiate handling, and the management of patients who are on opiates. This campaign is obviously intended to help address the opiate crisis in North America, and Canada certainly hasn't been immune from this as a major problem. And so it took the Choosing Wisely platform as a way to partner with other organizations to really try to address prescribing behaviors. For our Anesthesia Society, our core recommendations followed a strategy much like many of the other professional organizations and like the American campaigns. We surveyed our members at the beginning around a number of different areas of practice that we felt might be appropriate for addressing low-value care and reducing the rates. We asked our members to answer questions like, how frequent is this problem in your practice? How likely do you think we are at actually making change? Is this an impactful change for the system? And is the evidence there to support us cutting back on this low-value care? And when we pooled together the answers from our members in all the different areas we had asked about, it led to a fairly cohesive list of recommendations that revolve around preoperative investigations. That wasn't intentional, but our members suggested that each of these 5 areas met those criteria that I outlined in terms of high impact and also possibility for change. I've highlighted in red there a few words from each of the recommendations just to indicate that these really revolve around what we consider low value in low risk surgery. We were a bit cautious in that respect because we were looking for something that we felt that our members would be able to actually change and make an impact on. But there is a significant criticism of choosing wisely, both our recommendations and many others, that perhaps they haven't gone far enough. In fact, this has been the subject of a number of editorials over the years, suggesting that practitioners and physicians are very comfortable making recommendations around things that don't impact their income, that will make recommendations for organizations that are not their own, but they're really reluctant to make recommendations that dig deep into their own pockets. I think we are susceptible to that criticism. But if we look at our recommendations themselves, we know that at least in this area, there remains significant work to be done. So practice variation isn't new. I mean, that report in 2001 really spoke to practice variation across U.S. jurisdictions. And in the area of preoperative investigations, there is significant practice variation. This is an example of one preoperative testing grid that was put into place in around 2005. This is an expert consensus in the province of Ontario in Canada. And this Ontario preoperative testing grid got fairly broad dissemination. It became the foundation of many recommendations across Canada and even in US jurisdictions and some places internationally. But despite trying to guide people to be consistent in their decision making, we know that there remains significant variation. We did a study in 2015 and a subsequent investigation in 2016 looking at a very large cohort of patients who went low-risk surgery, low-risk ophthalmology, or endoscopy procedures here in Ontario and Canada. We looked at about 1.5 million individual patients who received over 2 million unique procedures. And that was across 137 hospitals in our province. What we found is that from hospital to hospital, the practice pattern in terms of preoperative testing is dramatically different. If we just look at the ECGs in this table, for example, in some hospitals, ECGs are done as infrequently as 3 to 4% of patients before low-risk surgery. On the far end, that goes as high as 89% of patients for some institutions. That's true across different investigations. You can see that there for transesophageal echo, for stress tests and chest x-rays. The y-axis is different for each of those, so bear that in mind. But that variability that we see from one hospital to the next persists across everything that we looked at. And when we tried to identify the drivers of this practice, some of the things are the ones you might expect. Age, for example, came out as a major driver of preoperative investigations. But the one that I think is worth us noting today is the fact that if a patient sat in front of an anesthesiologist or a medical doctor, they were 7 to 9 times more likely to get investigated with tests than if they did not. And that was after controlling for things like cardiac and respiratory comorbidities. This is purely the fact that a physician saw that patient and was therefore more likely to order investigations. We've tried to put tools in place in my jurisdiction to change this practice. We produced a report that goes out to every hospital in Ontario on a quarterly basis. It shows them their local testing practice, the number of ECGs and chest x-rays that they do locally, and it compares them to the cohort across the province. It shows them where they are and tries to encourage them to make change over time. We didn't put a benchmark for the correct rate of testing because we don't actually know what that is, but we can tell you that this practice variability is not appropriate given the homogeneous population across these different hospitals. Unfortunately, what we've seen is that even with this report going out to all of our institutions, it really hasn't been able to get the traction or drive the change that we had hoped for. Our professional organization here in Ontario looked to go further and to help empower anesthesiologists specifically to make change. They felt that this was an area where we could improve the evidence base of our practice, but also where we could demonstrate that anesthesiologists are stewards of the system, that they're partners with the government and with our other practice allies, and really enhance the profile of our profession in terms of making decisions that impact the system as a whole. They put together this implementation guide, which you can access through the Ontario's Anaesthesiologists website if you're interested, as a tool for helping drive quality improvement practice in Ontario. What we know from some of the investigations looking at the behavioral science in this area is that it isn't the evidence that people need to make change. It's really the relationships that we have in our perioperative environment. We asked anesthesiologists and surgeons why they perform low-value care, even if they know that it's not indicated. And what they told us was it's really about responsibility and about conflict between decision-making. So people are reluctant to cancel orders that someone else has put in. They are making decisions that cater to the most conservative member of their department, for example, or that the surgeons are ordering tests that they think an anesthesiologist might want, and they don't want to see their surgery canceled by the chance that they make a poor decision. So they order absolutely everything. These are the areas where we really need to intervene in order to drive change in reducing low-value care. So as we do this work and this research, what we've learned is that the perioperative environment is really about complex relationships, and that's probably no surprise to any of you on this talk. That individual decision-making probably drives this a lot less than we might have thought at the beginning. Family practitioner's office, our surgeon colleagues can make individual decisions in their offices. But in the perioperative environment, we are often making decisions for others or in a way that brings together a number of different providers. What we have found in Canada is that perioperative care models differ a lot more than we thought. And the impact of this on our decision-making isn't entirely clear. In Alberta, one of our provinces, for example, physicians are not paid an additional amount of money for their preoperative assessments, but in Ontario, they are. So does that mean that patients are more likely to see a physician? And if they are, does that mean they are more likely to get tests or less? We don't know the answers to those questions, and that's really the work that we're trying to do now on a national basis in Canada to tease out some of the specific system factors that impact these decisions. We hope that changing responsibility will have an impact. And right now we have a large randomized controlled trial on a national basis looking at changing the site of responsibility for these decisions to anesthesiologists, and in large part taking that responsibility off our surgeon's shoulders. Since we are the end user of a lot of this information, it makes sense that we would be the ones that might make the most evidence-based decisions. We don't actually know that's true, but we're thinking that that will be based on the surveys and preliminary work that we've done. Hopefully in a year or two, we'll be able to give you those answers. Unfortunately, as you know, no talk right now is complete without reference to the pandemic. And we don't know how the changes we've seen in the last year and a half are going to affect choosing wisely and low-value care in the perioperative setting. At my institution, you can see what's happened to our preoperative visits in terms of in-person versus virtual care. Almost entirely now, we're seeing our patients over the phone or by video calls before their surgery. I can tell you at my hospital that hasn't changed our preoperative testing practice, at least anecdotally. But what I don't know whether that's true at a system level. Are physicians more likely to order tests because they are not seeing patients in person and they're reluctant to make decisions just based on a phone call? Or are they less likely because patients rather are not in hospital during their preoperative clinic visit and it's harder for them to get the test? I don't know. It's possible the pandemic has really helped us drive decision making around low value care forward, but it's also possible it's set us back. And again, we have a large cohort study underway right now to try and answer that question for us. The short story here is that Choosing Wisely in Canada is very alive and well. It's robust. It has research and funding driven to help us answer many of the questions around how low-value care decisions are made and how we can effectively support physicians and other practitioners in terms of changing their practice. Our particular recommendations are pretty standard. They look a lot like the American ones. They look like a lot like the Australian ones and New Zealand recommendations. And these are pretty consistent across countries. But perhaps in Canada, we have an environment where anesthesiologists can actually own our recommendations and maybe actually make impact that we haven't seen in other jurisdictions around producing this low value care. That said, we're 7 years into our campaign and we haven't seen the impact that we really would have hoped for yet. So hopefully our research around the behavioral science aspects of this can help us really make those inroads and produce change. Thank you very much for the opportunity to speak to you.